Uh, I think we are just 2-3 minutes behind.
Correct.
I'm just waiting for the other speaker, Dr. Himanshu and Dr. Bindul to join.
Sure.
And we have got 17, 18 participants now. People will join. They
Sure.
usually take some time.
No, sure. You have reached safely? Yeah.
Hello.
Yeah. You have reached airport safely?
I think you are on mute. You are not audible, madam.
I can.
Hello?
No, I'm not on mute now. Can you hear me now? Just see.
Madam, you are not audible. You can start sharing your slides till the time these people join.
Can you hear me now?
Yeah. We can hear.
Okay.
Can hear you. Yes.
Okay.
So already, I think already 20 delegates have already joined. So just 2-3 minutes.
Hello, am I audible?
Yes, we can hear you.
Yeah. So just waiting for Dr. Himanshu to join. I think you can start sharing your slides, madam. Yeah.
Yes.
So at least, or if you can start the session with Dr. Juhi, and then Himanshu will be presenting his session. Will be okay without wasting much time.
Yeah, sure.
So by the
madam, can you get it on a slide mode?
Yeah, I'm on the slide mode now.
Yeah.
Sure.
Yes. Yeah.
So, welcome everyone to this 27th episode of Apollo Mumbai Critical Care Learning Network. And today we'll be having a very interesting session on sepsis. As the name suggests, there is always some or more research always going on every corner of the world, sepsis. And every time we take sepsis, we find something new. So, as the years advances, so let's see what are the changes of this surviving sepsis campaign. So initially when we started the sepsis, and now we are in our latest campaign of 2021. And going ahead further, what will be our newer therapies in sepsis in 2023? So today we have three eminent speakers and panelists also, and moderators also will enlighten. So I welcome you all, and I hand over the mic. I am Dr. Nathar Pai. I am the consultant critical care medicine, and I am handing over this. And you will start with the introduction, and then will be start with the session. Douglas, can you start with?
Yeah, thank you, Dr. Gunadhar. It is indeed a great pleasure to. Yeah. Am I audible now?
Yes.
I hope I'm audible.
Yes.
Yeah. So good evening, everyone. Today it is indeed a great pleasure to have majority of the international speakers for this virtual program of Apollo Critical Care Learning Network. And today the emphasis will be on sepsis. And we will discuss about what new changes have been incorporated in 2021 sepsis guidelines. And for this, I would invite Dr. Juhi Chandwani. Dr. Juhi Chandwani is the critical care consultant at Royal Hospital, Muscat. And she has been in intensive care since quite a long time, and she has a lot of stories to tell us about the sepsis. But today she would be emphasizing on the new changes that have been incorporated. Following her, we will have Dr. Himanshu Roy, who will be discussing genetics in sepsis. And we have, till now, we have not been able to understand the basic pathophysiology of sepsis, and he would like to open up the new entities and what is the basic genetic problem that is there, because every individual behaves differently when somebody acquires infection, and the inflammatory response also varies from individual to individual. So today, Dr. Himanshu Roy will be highlighting those key points. And following him, we will have a discussion on organ support. Professor Bengal will be joining us, and he is the director of this company. And we will get to know a lot of things about supporting the organs. It's not just supporting kidney, liver, heart, and brain, but the metabolic, control is also very, very important, and he will be highlighting those insights. So, with this background, I would like to invite Dr. Juhi, and she doesn't need any introduction because she's quite popular and famous intensivist in Muscat, and that too in Royal Hospital. So, with this, I would invite you, madam, and please,
And
start the session.
yeah,
Yeah.
and before I think Madam will start her talk. So I'd like to introduce the other moderator for today's session, Dr. Swapnil. Dr. Swapnil Khatte is our junior consultant working in Apollo Hospital. And today with us, Dr. Divya, she's a consultant and intensive care medicine. So with this, let's over to you, madam.
Yeah, okay. Okay, good evening, everyone. Thank you for inviting me, Dr. Akhilesh, and for your kind invitation. So I'll straight away start the topic. So we are going to talk about surviving sepsis guidelines and what is new. So we know that the Surviving Sepsis campaign started way back in 2002, which was a collaborative initiative between three intensive care societies: the European Society, the Society of Critical Care Medicine, and the International Sepsis Forum. And that was mainly started because of the growing menace of the sepsis, which was killing almost 60 to 70% of the patients. The objective of this campaign was to develop and promulgate evidence-based guidelines for sepsis and to facilitate the application of knowledge derived from clinical trials to bedside practice. So we always have studies, but end of the day, we are not able to apply those things to the bedside. And that was the main purpose of this campaign, to make these guidelines easy to be followed at the bedside for the patient management. And their pure aim was to reduce the mortality rate by 25% of patients dying from sepsis and septic shock. So the question remains, did they achieve that? Well, yes, over the years, we'll see over last 20 years, these sepsis guidelines, they are updated every 4 years. So we have seen 5 sets of updated guidelines till now. And 2021 was the last when these guidelines were updated. And we have seen significant reduction in the mortality. Like you can say we started from 60 to 70%, but now in some of the best centers, the mortality rate from sepsis has come down to almost 30 to 40%. So what are the new challenges that we are facing? So every time the guidelines are updated, they're looking at the new challenges. So we all know the current challenge is not only survival, it is the survival with a better quality of life. We have loads of survivors. Out of 1.7 million patients of sepsis that we manage in the ICU, almost 1.4 survive, but they survive with a lot of long-term complications. So the current guidelines, the 2021 guidelines, have increased emphasis on improving the care of these septic patients after they are discharged from ICU. Many patients survive the ICU, but they don't survive to hospital discharge. And moreover, they don't survive to a better quality of life. It includes greater geographic and gender diversity than the previous versions. And their main aim was to address this challenge of treating patients which were experiencing long-term effects of the sepsis. And here in these new guidelines, they have recommended involving the patients and their families in the goals of care. with early and ongoing follow-up with the clinicians and the rehabilitation services. Most of the intensivists, our job ends at the ICU, we feel. But your aim should not be just to survive the ICU, but your aim should be to survive till they reach home. So we need to be involved in that, and we need to ensure that this care is provided beyond ICU. And that's what the new guidelines emphasize on. So we know that the recommendations that are there in the guidelines are based on the quality of the evidence, and based on this quality of evidence, there'll be either strong recommendations or weak recommendations. So the level of evidence will be either a strong evidence, that is level of evidence will be A, if it is based on high quality RCTs, if we have studies done on that particular recommendation. And accordingly, the level of evidence decreases, the quality of evidence decreases to B or C if you don't have RCTs for those recommendations, or you have just observational studies, and the level of evidence becomes much lower if they are based on just simple observational studies or expert opinions or based on your case reports and all. Moreover, you have several best practice statements in these recommendations which represent ungraded recommendations in which the evidence was either considered unequivocal. Like you have statements, like you have studies in favor and in against. So the evidence is 50-50. You don't have strong RCTs, or they're awaiting stronger RCTs. So based on that, you will have these kind of statements. Like you will have statements like phrases like we recommend or we suggest. So when they say we recommend, the statements would be either strong statements which are ungraded, that is you don't have RCTs for that, so which will be labeled as best practice statements, or it will be strong graded where you have strong RCTs to support that statement. In that situation, the phrasing will be we recommend. When you have weak graded evidence, it will be a suggestion which will not be a recommendation. So when you say the evidence is strong, and whether it is a graded based on RCTs or it's a best practice statement, then these statements, almost all informed physicians or the people who are managing the patients will be choosing this intervention. That is 95% of the people have to follow these recommendations. So it will have a widespread adaptation. Moreover, the newer guidelines recommend that you should do performance assessment of these statements. So when you are going to do performance assessment, you are going to include these statements. Whereas when the statement is weak, then you will have almost 60% of the people will be following these recommendations. But they are still important recommendations, but only 60%. So you can't use this for your performance assessment in your institutions. And the recommendations, which of these will be weak? If you see, when the recommendation is low, clearly, when the evidence is low, like it is based on observational studies or like case reports and case series, or there is a close balance between desirable and undesirable effects, or there is a variation or uncertainty based on patient values and preferences, or these recommendations cannot be applied in most of the institutions because every institute doesn't have those kind of resources to follow that. So these become weak recommendations, and on these weak recommendations, you cannot base your performance assessment. Okay. So now, whenever you have evidence, you will have like this either no recommendation, best practice statement, or weak recommendation, where the weak recommendation will be either the quality of evidence is low, or it cannot be applied because the institute doesn't have the resources to follow that. So if you see the overall guideline statements, they are divided into various topics. Now you can either go based on the topics, like you can have topics on screening and resuscitation of septic patients, topics for infection based on hemodynamics, ventilation, additional therapies of sepsis, or goals of care and long-term outcomes of the patient. You can take these topics and you can see what recommendations you have. And they will be divided into either strong recommendations, weak recommendations, or best practice statements, or no recommendations. Or we can look at the guidelines based on the recommendations. So which of them are strong, which of them are weaker recommendations. So the beauty is, if you go to the Surviving Sepsis website, it is very beautifully divided. you can see on the left-hand side, there is a column which says the guiding section. This is the various sections under which the recommendations are divided. Now you can choose any of these. Like you can see, I want to know what is the recommendation about admitting these patients to ICU. So you will click that. And you want a strong recommendation, a recommendation based on a strong evidence. Now, if you choose that, then you will be able to see only those recommendations. So the Surviving Sepsis website has really become very beneficial for the end user to select the guidelines or the recommendations that you want. Now, as we said, we can either use this. Now, if you see this, you can specifically look at recommendations based on the therapies, or you based on the admission to ICU, based on your hemodynamic management. Or if you go back to your slide, you can see we can go based on the recommendations. So I have decided to go based on the recommendations today. Let us look at which are strong. Now, if you see these markings, these two arrows, if it is two exclamation marks, if it is green, that means it is a strong recommendation, strong graded recommendation. Okay. So let us look at what are the strong graded recommendations for adult patients with sepsis or septic shock, that you're sure patient is having sepsis or septic shock. So what are the recommendations when you're going to manage these patients? So one of the recommendation is you should give a restrictive transfusion therapy. No more it is recommended to give like large amount of blood transfusion to achieve a hemoglobin of 10. No, your transfusion trigger of 7 is more than enough for most of the patients, because blood itself can be a cause of the sepsis, or it will have its own issues in patients. Moreover, they recommend using pharmacological VT prophylaxis unless contraindicated. So there is strong evidence for using pharmacological VT. You can have your own criteria in your own institutions, whether you want to use unfractionated heparin or you use fractionated heparin like your Clexane, or you may use even Fondaparinux. The individual institutional practices can vary, but a pharmacological based VT prophylaxis is strongly recommended. Third recommendation is using IV insulin to maintain your sugars to 10 millimole per liter. So depending on the unit, you can use your milligram per DL. If you're used to that, you multiply it by 18 and you will get that value for you. Coming to the fluids resuscitation, the type of fluid has been a matter of debate always. Crystalloids remain the mainstay of resuscitation, and colloids are not recommended anymore nowadays, except albumin, which you will see later. It's not a strong recommendation, but it's a suggestion. Coming to the vasopressor, if your blood pressure is not maintained with your fluids alone, and if you have to use the vasopressor, then noradrenaline remains the first line agent. Coming to the antimicrobial agent, if your patient is definitely having sepsis and you're sure about it, then better to give antimicrobials within 1 hour of recognition of sepsis. And if you're using vasopressors, you should need a targeted measurement. That you should aim should be to maintain your BP of 65 millimeter of mercury and not higher. So no need to give large amount of vasopressors to achieve 80 mean blood pressure. For all patients, at least try to maintain mean blood pressure of 65 millimeter of mercury. Moreover, a strong graded recommendation is to have a performance improvement program in your institution for sepsis, including sepsis screening for acutely ill high-risk patients. Like unless proven otherwise, think that your patient has sepsis and screen them for sepsis and have a standard procedure for management of these patients. Now, and suppose if your patient develops ARDS due to sepsis, then use a lung protective strategy of low tidal volume of 4 to 6 ml per kg over high tidal volume, have a targeted pressure of plateau pressure of less than 30 wherever possible, and use prone position early and maintain prone position for more than 12 hours for managing ARDS in a septic patient. These are very strong recommendations. Now, when you have 2 exclamation marks with a red background, that means there is evidence for not using these strategies. And what are those? Right? Starches have gone out. You cannot use starches for resuscitating this patient. Use only crystalloid. Using Q-SOFA, which was like, coming up in last 2-3 years. Now, Q-SOFA is no more recommended for using as a screening tool for sepsis. You can go back to your usual tool of SIRS, or you can adopt your MUSE, that is your modified early warning score, where you group your standard parameters of temperature, pressure, blood pressure, and your saturations, and you decide whether your patient is moving away from the normal category, and that you use that tool to alert the system that your patient is developing sepsis. You increase the level of monitoring for the patient, or you start managing these patients. Again, coming to the PEEP with recruitment maneuvers, incremental PEEP is no more recommended for recruitment maneuvers. Now we come to suggestions, which are based on lower evidence, lower quality of evidence. Now, what are against? That is one arrow. Whenever it is suggestions, it will be one exclamation mark, and against is red background. So what is against that? Again, there is no strong evidence to use immunoglobulins, which was recommended in the last guidelines. No strong evidence for using hemoperfusion, for removing the endotoxins in septic shocks. Lot of this perfusion, hemoperfusion techniques were recommended. Nowadays, it is no more recommended, so no need to go and look for these therapies anymore. Using for VT prophylaxis, in last recommendations, they were recommending using combination VT prophylaxis, that is mechanical for plus pharmacological. Currently, they are only recommending pharmacological prophylaxis. Moreover, in sepsis patients with kidney injury, there is no definite indications for RRT with no definite. If suppose your patient has no AKI, people were using renal replacement therapy as purification technique, like to remove endotoxins, like high volume renal replacement therapy. It is no more recommended, no more suggested to use. You use renal replacement therapy only if your patient has acute kidney injury. Vitamin C, which was the major thing in last 2-3 years, where we have lot of studies in favor of vitamin C. Again, now it has gone, we have enough evidence against it. Again, cheaper therapies always go out of vogue very easily, and vitamin C is one such therapy. There is no evidence to use it, but definitely it's not harmful. Coming to soda bicarb, which was used to improve hemodynamics or to reduce vasotherapy, it is no more recommended for using for improving hemodynamics. You can use it to reduce your acidosis, that is to buy time until you prepare your RRT machines, but definitely not to improve your hemodynamics. Starch gelatins are not suggested for resuscitation at all. Again, terlipressin has gone out of vogue. Patients with heart failure in septic shock, levosimendan is no more recommended. What is recommended is using your volume status and using your vasopressors, but not levosimendan. Again, procalcitonin was being highly recommended for diagnosing sepsis. It is no more recommended to start your antimicrobial therapy. So if you don't have procalcitonin, it's absolutely fine. You can still manage your septic patients using our clinical guidelines. Using empirical antibiotics with MRSA coverage, again, is not suggested, especially when there is no strong evidence to suggest for MRSA. Then there was a lot of talk about using empirical dual cover for gram-negative sepsis. Again, suggestion is against it. You can just use one antimicrobial agent for gram-negative agent. Single agent is enough. For antifungal use, it is no more recommended to use empirically. You can use it for treating if you have a fungal infection documented. Then routine formal palliative care consultation for all patients is not recommended. What is recommended is if based on your clinical judgment, you feel this patient should be for palliation rather than for active management, then only you refer these patients for palliative care. Not all patients should be suggested for palliative care. Now, what are these suggestions in favor in patients who are strong, have evidence of sepsis and septic shock? Now, these are suggestions which are based on weak recommendations, but still most of the 60 to 70% of the people would follow this therapy for management of sepsis. That is, first and foremost is your use of IV corticosteroids. Remember, there is no grade 1 recommendation. Most of the grade 1 recommendation did not support steroids, but there is enough evidence to say that corticosteroids will help to reduce your vasopressor requirement. So once you are on the second vasopressor, you may use IV corticosteroids, and there is a strong suggestion. So most of us do use corticosteroids when our inotropic requirement goes very high. Then use of stress ulcer prophylaxis. It is again highly suggested, and we all do use it to prevent GI bleeding, because critical care is a major risk factor for developing stress ulcers. So we highly recommend it. Again, there is a local policy. If your patient is nicely tolerating enteral feeds, you may stop using a stress ulcer prophylaxis. The main concern is the development of hospital-acquired infections when you are using large amount of stress ulcer prophylaxis. So you can consider stopping it if you are on good enteral feeds. But if your patient is NPO and all, in initial 48 hours, it is highly recommended, like highly suggested to use this. Coming to septic shock with AKI, you have to use renal replacement therapy. Again, there is no strong suggestion for using renal replacement therapy in the form of CRRT. If you have only intermittent hemodialysis, it is equally good. You should just know how to use intermittent hemodialysis in patients who are on high dose vasopressors. Now, coming to septic shock with severe acidosis, only in patients who have acute kidney injury, you may consider soda bicarb if you cannot start your renal replacement therapy immediately. Otherwise, we do not recommend using soda bicarb. Patients who can be fed enterally, it is suggested to start using enteral nutrition as early as possible, and enteral nutrition is any day preferred over parenteral nutrition. And patients who require ICU, it is suggested, if possible, try to get the patients within the unit within 6 hours. Because if you delay it, the care is going to go down and your mortality is going to increase. Coming to use of crystalloid, the type of crystalloid fluid, a balanced crystalloid is suggested over using normal saline. However, if you don't have balanced crystalloids, and if you have only normal saline, it's not that you cannot use it, but you have to use it with caution, but with better monitoring. You monitor your chlorides. The risk is of your hyperchloremic acidosis, and that's what you need to prevent in this patient. Albumin is again suggested. You can consider it as a volume for volume replacement compared to other starches which are totally out. Albumin is still remained in the guidelines. Coming to the type of vasopressors, vasopressin is suggested to be added once your adrenaline doses has been increasing beyond certain level. Again, there is no strong recommendation as to what is a higher level of norad. So again, you go to your institution practice, you can use up to 2 mics per kg per minute. But if you're using vasopressin, you can start using it earlier, like when your dose of norepinephrine is 0.5 to 1 mic per kg per minute. So you can balance it with a combined therapy, because vasopressin acts with the different receptors. When your patient is having septic shock along with cardiac dysfunction and you're not able to maintain your blood pressure, then it is suggested to add dobutamine to noradrenaline. Or you can use adrenaline, which has both the effects. It has a vasopressor effect plus an inodilator effect. So you can use adrenaline alone, or a combination of noradrenaline and dobutamine works much better. Adrenaline can have arrhythmogenic effect. The most important is to monitor these patients. And one thing that has strongly been suggested is to use your invasive monitoring. Use your cardiac output monitoring devices if you have. Again, why it has become a suggestion rather than a recommendation? Because most of the institutions may not have these facilities. So, but if you have a facility, you definitely use it. So it cannot be used as a performance. You cannot be considered as negligent if you are not having invasive monitoring. So you cannot use it as a performance improvement measure. But if you have it, you must use it to manage this septic shock patient. Coming to adults with less likelihood of infection and without shock, you can defer your antimicrobial therapy. It's not like you have to use within 1 hour. If you're not sure your patient is septic and you are in the process of still working out, you're still investigating, you can delay your antimicrobial therapy. And the time factor is up to 3 hours. You can delay. If within 3 hours you're still not sure and you're going more in favor of sepsis, then you should still can give empirically antibiotics. So a time-limited course of rapid investigation is recommended within 3 hours when the sepsis was first recognized, while you're still investigating your other causes. Coming to MDRO infections, only when you have a strong MDRO infection, when you have an outbreak and you think that there is a very high chance of MDRO in your patient, then you may use 2 antibiotics. for having gram-negative coverage over one antibiotic, only when you have a strong suspicion of MDRO infection. If you are using meropenem, beta-lactams, then rather than using boluses or intermittent dosage, a prolonged infusion is recommended because it is shown to have a better effect. For septic or septic shock at high risk of fungal infection, only in these patients, they suggest antifungal after you have given a course of your antibiotics. Then you may consider empirical antifungals. Moreover, it is important to daily assess the patient for de-escalation of these antimicrobials. Never use it for fixed duration. You cannot say that my institution says 5 days. No, these patients should be assessed on a daily basis. You may stop it after 2 days also. But you need to have a daily assessment of, can I stop the antibiotics? Can I de-escalate it? Maybe your cultures are saying your patient is responsive to a simpler antibiotic. So reduce it from meropenem to tazocine, from tazocine to augmentin. What is important too is to have an adequate source control, and depending on the source, to give an optimal duration of sepsis, optimal duration of therapy. Now, in such patients, when you have adequate source control and you are not sure whether you can stop antibiotics or no, only in these patients, and if you have the facility, they suggest using procalcitonin to guide stopping of your antimicrobial therapy, okay, over clinical evaluation alone. So in septic shock patients, at least 30 ml of fluid should be given within 3 hours of resuscitation. It is important to have a dynamic measure of your fluid resuscitation to guide your fluid resuscitation, like use your ultrasound tools, use your IVC collapsibility, and you can use lactate rather than using a single level, use a decreasing level of your lactate to guide your therapy for resuscitation. And the best thing is, currently the recent evidence has come out that you can use even your capillary refill time to guide your resuscitation if you don't have your lactate. So that is the beauty of using your baseline clinical assessment tools. So even that is seen to be as good as your lactate measurement. Moreover, you have to address your goal of therapy early, like within 72 hours. You should try to reach your goals, like your target blood pressure, target target capillary refill times. You should be able to reach your goals therapy, like you're getting your glucose control, trying to get your source control as soon as possible. Then there is a lot of emphasis on long-term goals. That is, for adult survival of sepsis, a referral to a support group should be done as early as possible. That is what is suggested if you have a facility. Moreover, there should be a clear handoff process at a transition point from ICU to ward to a rehabilitation center. Then from ICU to ward or to ICU to prolonged ventilation centers, like your chronic ventilation centers. There should be a clear handoff process, not a specific handoff process. You can use any handoff process. You can develop your own, but there should be a clear handover process. And there should be a written and a verbal education resources is suggested to be given for patients and their families and to the discharge facilities. So these will help in better management of these patients and will have better outcome of these patients. This should be provided to the families also upon transfer to the fore. There should be a better follow-up programs. Like there should be a critical care OPDs, post-critical care OPDs, where a patient should be given a follow-up appointments. Like there should be chronic ventilation programs, where if the patient has received ventilation for more than 48 hours, or their ICU stays more than 72 hours, then a referral to a rehabilitation program should be done early, so that they can start their process while your patient is in ICU, not after they reach the rehabilitation program. All this has been shown to have a better outcome, a qualitative outcome, where a patient can have a meaningful life once they reach home. Coming to suspected sepsis, they suggest measuring blood lactate to guide your therapy. And when your patient has hypoxic injury, hypoxic respiratory failures, and you're still in the process of diagnosing, patient does not need ventilation, then you can consider non-invasive ventilation. But if you have a facility to use high-flow nasal cannula, they recommend high-flow nasal cannula over non-invasive ventilation. Coming to respiratory failure without ARDS also, even when you are using non-invasive ventilation, Even in those situations, you should use low tidal volumes and not just allow patients to have high tidal volume, because that is going to lead to lung injury. And suppose these patients get ventilated, unfortunately, later on, they will have worse outcomes. So low tidal volume should be maintained right from the beginning till your patient gets ventilated. And, and when the patients develop ARDS, then to reduce these tidal volumes, you may use neuromuscular blocking agent, that is your muscle relaxants. And they prefer intermittent boluses rather than continuous infusions, because a prolonged neuromuscular blockade therapy will lead to myopathies and again will lead to delayed recovery. There are certain things which are out of vogue now. That is which are the strong things which have totally gone out, where there is absolutely no evidence now or insufficient evidence. That is blood purification techniques, restrictive versus liberal. So for liberal fluid therapy, again, the recommendation is not in strong favor. They are trying to say that you can use your liberal fluid, but you have a proper monitoring. You, if possible, try to restrict fluids, because larger volumes have shown to worse outcomes. Antiviral therapy not recommended empirically. You can use it if you have strong evidence. For using any structured handoff, no strong recommendation. Early post-hospital discharge follow-up. Again, if you don't have a facility for discharge OPDs, like post-follow-up OPDs, it's fine. But if you have it, it will be better. On the use of conservative oxygen targets, there is no strong recommendation, but we all know that we don't need to have 100% saturation all the time. But you should have meaningful targets of about 94% saturation. Coming to use of NIV in compared to non-NIV, it's again equivocal. They have left it to the clinician to decide. There is no strong recommendation. Now, there are certain best practice statements, which is again based on ungraded evidence, mainly based on expert advices. So when we are dealing with suspected sepsis, but unconfirmed infection, they recommend continuously re-evaluating the patient for alternative diagnosis. You don't have to just give antibiotics thinking, oh, my time is going, so I have to give antibiotics now, whether you know it is sepsis or no. No, you can still continue diagnosing sepsis up to 3 hours, but you have to be rapidly diagnosing. You can't just wait for 2-3 days. For possible sepsis without shock, rapid assessment of this condition should be done. When it comes to all sepsis and septic shocks are medical emergencies, and the resuscitation should start immediately. And for when you have confirmed sepsis, when there is high risk of an MRSA, you should try to include MRSA coverage in your this thing, and you should optimize the dose of antimicrobials using your PK/PKD property. Then source control intervention as soon as medically and logistically possible. And in source control, removal of IV devices come very high, and you should try to establish other sources and try to remove the highly suspicious lines as soon as possible. You should discuss the goals of care and prognosis with the patients as early as possible. The principles of palliative care should be integrated into the treatment pool. And you should have early screening for economic and social support, and make referrals wherever possible to meet these demands, so that you can provide better care when the patient moves out of ICU. One thing very important is reconciliation of medications. It is important to know what patients are background medications. How is patient managing its medications? So these reconciliation of medications at every transition point is highly suggested. Now, there is no strong evidence. There is no RCTs done, but most of the best practice statements say that it is highly recommended. There should be a written and a verbal hospital discharge summary, and the discharge plan should include follow-up with the clinicians. So there should be follow-up appointments given, either with the clinicians or with the ICU OPDs if you have a post-ICU OPDs. And this assessment should include physical, cognitive, and emotional problems after hospital discharge. So if you look at the strong differences, let us look at, like, from 2016 to now, the most of the recommendations are the volume of IV fluid and the timing. This has been downgraded from strong to weak. Now they are just suggesting to use 30 ml per kg. So you have to individualize it. It's not that any patient, even if he has some evidence of heart failure before, they used to say give 30 ml per kg. No, Now they are telling if your patient is overloaded already, you can reduce your amount of fluid and you can guide it with your monitoring. Coming to type of evidence, type of fluid, again, they strongly recommend using balanced crystalloid fluid and no more. They are in fact going against normal saline. If you can avoid using normal saline, avoid it. The route in the older guidelines, the route of vasopressor was not recommended. Currently, they are recommending don't have to wait for central line. You can start using your peripheral lines for using your vasopressor, but use early. Try to reach your goal of care early of reaching your mean blood pressure of 65. But use proper dilution when you're using peripheral. Vitamin C has gone out of vogue now. Then IV corticosteroid, they suggested against using initially, but now they're suggesting to use once your patient is going with two inotropes. Psychological support was not addressed, but now they are telling you start this support much early within the ICU itself. Type of antimicrobials, we have already covered this before. Include your MRSA coverage and antifungal only if you have strong some evidence. So what is important is the focus on the performance measurement tool. One such tool which we use, which is probably adopted from some other guidelines, is you have this kind of tools in your institutions, like which includes your recognition bundle. Screen your patients for sepsis when they enter your ICU, like or in the hospital level itself, whether they have fever, and look at whether what is the source, like line associated, whether this, then start marking them. You should have, this can be used as audit tools, that whether this patient has and how fast it was done for your patient. And if this patient is showing now more in favor of sepsis, like the blood pressure is low, lactate is high, yes, start responding early, escalate the care, and then you use it as a performance, how fast this was done in your institution. And then go back to your sepsis management bundle, like resuscitation bundle, whether the patient was given airway management initially, immediately, given oxygen within some time, within 10 minutes. Was he, IV line was inserted within 10 minutes? Was the fluid given within 1 hour? It was addressed. Well, the goals of care achieved within your 1 hour. So you should have the measurement tools and monitoring tools in your institution, whether you are able to achieve this goal care and how you are able to achieve. And if not, what was the cause of the delay? So these are the performance improvements tools they are recommending to follow. Again, coming to the management bundle, within 24 to 48 hours, were you able to reach these bundles? Were you able to achieve your glucose target? Were you able to achieve your urine output target? Were you able to do your sepsis source tools from head to toe? Then your 24, what is the reassessment plan? Then where is your patient reached? Whether he was able to come to ICU within 6 hours. If not, what was the cause of delay? All these should be checked and a assessment should be done. And you should have a protocolized management, how you're going to manage this fluid, how the how it was monitored and how much fluid was given, when the lactate was measured for these patients. And you should have your own antimicrobial policy in your institution. So all these performance improvement tools are going to improve the management. And they say if you cannot measure it, you cannot manage it. If you measure it in your institution, you'll be able to manage it better. So this will form your bench line and you will have better outcome. So thus to conclude, the data has strongly suggested that using this survival sepsis guidelines and this protocolized treatment has associated with better survival. Whereas if you don't follow, there is increased mortality. Any hourly delay increases the rate of mortality in any institutions. Most SSC recommendations, however, were supported mainly by observational studies, if you go to see, or case reports and expert opinions rather than strong evidence. In fact, there is strong evidence only for 15 to 20% of these guidelines. So hence the clinician should consider these recommendations and ultimately choose the best care option based on the individual patient's clinical status and the expertise available in your institution. But these form a main benchmark which you can use. So remember, these are just bundles and their intentions are good, but they should not be misunderstood and applied correctly. That's all I have to say. Thank you.
Oh, thank you very much. Thank you, Madam, for this wonderful insight and very holistic approach. And you have, rightly, differentiated the changes I think it will be really useful to the students. There is one question in the chat box
Yeah.
pertaining to the use of steroids, whether the
Yeah.
steroid should be used in continuous infusion or
So,
intermittent
can we
dosages.
just take the question, like take
Yeah,
the questions in
we
the
will,
end of the lecture because
yeah, we can take this question later on, and I would like to invite Dr.
Sure. Thank
Himanshu
you.
Diwan. Yeah, yeah. Please, we will join the question answer later, madam. So, Dr. Himanshu Diwan is the Associate Director of Medicare Hospital, and then he has been in intensive care since last 15 years, and he has a special interest in sepsis and hemodynamic monitoring. Today, he is going to discuss the genetics in sepsis. So, can I invite Dr. Himanshu?
Sure.
And over to you, sir. Please start sharing your screen.
So, am I audible?
Yes, yes, you're audible.
Good evening, everyone, and thank you, Dr. Klesh and Gunadhar, for this wonderful opportunity. You have a great platform going, and I was listening to Dr. Joy's talk, extensively covered, uh, very nicely explained, and I am pretty hopeful everybody would get a lot of clarity on how to go about the sepsis guidelines. The task given to me today is I'm going to discuss genetics in sepsis. Is this the way forward? Uh, I am not a genetics expert. That's my disclaimer to start with. I am a clinician who likes to look at things objectively and see what the current research helps me guide better in my patient treatment. How do I choose the modalities better? I started getting interested in this area of critical care maybe last 6 months or a year. And I hope my presentation would create some interest in our audience as well. So my experience in critical care is not 15, it's 20 years now. I started in 2001. Uh, and if I can look back in my career, and I can see that as a young resident to a postgraduate student to a fellow and then a consultant, I have seen these things happening in front of me. So we've been fortunate to be the generation where we saw that we were trying to figure out what is the difference between sepsis and infection, try to define sepsis, try to get some scoring methods to look at the sick subgroup of patients, try to define things as heterogeneous as ARDS, and gradually got to the sepsis 3 definition, the latest ARDS definition, possibly get rid of some useless scoring system like QSOFA. So we gone from a generation which saw foundation to acceleration, and now at the end of acceleration phase, where we know a bit about these heterogeneous syndromes like sepsis and ARDS, we have scoring systems to predict some mortality in such patients. But what we are lacking is precision. By that, what I mean is that if we look at the past 30 years of critical care research surrounding sepsis, we haven't had a single drug recommended across all platforms which helps to get down the mortality of sepsis. Don't get me wrong, we have been able to get down the mortality of sepsis, yes, in the last 10, 15, 20 years, but that's basically because of the more protocolized and guided resuscitation measures, more guided protective ventilation measures, probably the timely, adequate, appropriate antimicrobial therapy. But as we understand sepsis being a dysregulated immune phenomena, we don't have a single drug recommended of 30 years of research that takes care of the dysregulated immunity, which the sepsis guidelines recommend. And if you look at this paper, a very interesting paper from Mark Cavanaugh and Mervyn Singer and the group, you would see why have we failed. We have failed because our preclinical research is basically using a murine model. Now, if you look at the murine model versus a human model of infection, there are stark differences. You really cannot compare these two. A murine model, for example, the inflammatory marker is SAP, in humans it is CRP. The dominant leukocytes in murine models are lymphocytes. For human, it is neutrophils, and a lot of physiological differences, a lot of immunological differences in complement and all. So the preclinical research, a lot of things got buried in preclinical research because we are unable to show that these things are beneficial, which they might actually have been if they had considered a ex vivo human model. And that's the new concept of ex vivo human models. The second reason I believe we failed in getting the right drug was that we tried to fit one shoe to all. And we did not really look at the use of those specific drugs in the specific subgroup or cohort of patients which may actually benefit from these drugs. Hence, a lot of drugs which initially created some interest were used, things like activated protein C or IVIG, gradually in subsequent trials, because we did not choose the cohort of the patient appropriately, they failed and they never got a strong recommendation. Things like activated protein C actually got removed from the market. And that is where possibly the things went wrong. And people are trying to rectify this. Now, this is the basis of my presentation. Let's look at two case scenarios. In the first case, case one, you have a 65-year-old male who's got comorbidities, diabetes, hypertension, a coronary disease. He comes to the ICU with a community-acquired pneumonia of 5-day duration, hypoxic respiratory failure, and you have streptococcus pneumonia as the culprit. This gentleman comes hard onto the ICU unit, went into multi-organ dysfunction, gradually multi-organ dysfunction leads to multi-organ failure, refractory shock, and he dies, right? And another case, which looks like a speaking image of that first patient, maybe a twin of that patient, same age group, same comorbidities, a community-acquired pneumonia, similar organism profile, has got much milder symptoms, much milder hypoxia, may or may not need ventilation, doesn't go into multi-organ dysfunction, and recovers. Now, this makes us think, why is there a difference? Why is a difference that two patients with similar profiles behave so differently to the same insult? And that's the basics of genetics when you're looking at patients of sepsis. The pathophysiology of sepsis, and I try to make a very, very simple image, not to bore you with the biomarkers and all the complexities of the cascade. Let's look at this very, very simply. What you have is, you have an insult coming to the human body in the form of a pathogen, a gram-positive, gram-negative bacteria, virus, fungus, whatever. And these organisms carry pathogen-associated patterns. Okay. Now, these patterns, once they are recognized by the human body, and that is where the difference is, we respond by damage-associated molecular patterns, DAMPs. And those are the cytokines which we release, which lead to the activation of the complement pathway, the dysfunction of the endothelial system, dysfunction of the the neurological system, modulation of metabolism at tissue level, and immune cell reprogramming. And this cascade of mediators which is released is normally called the cytokine storm. Now, the cytokine storm has a lot of mediators. Some are pro-inflammatory, some are anti-inflammatory. So the basic difference that arises is how a body behaves in response to the antigen which is presented to the human cells. And these are different for different people based on their genetic diversity, their gender, their age, their comorbidities, their microbiota, their ethnic groups, Caucasians, African Americans, Asians, they all behave differently to similar insults. Whether they have substance abuse, do they have previous viral reactivations? All of these factors together are responsible for the way a body responds to a similar pathogen. Two people behave very differently. This cartoon here, I try to demonstrate why do some patients, let's for example, a patient who's got streptococcal pneumonia, and somebody develops AKI, somebody develops more hepatic dysfunction, somebody develops more CNS manifestation. Why does this happen? This happens because the compartment specific reprogramming of macrophages happens in sepsis. The microenvironment modulates the response of macrophages due to sepsis. So the same modulation may be more in one patient in liver and more in CNS for the other patient, more in the kidney for the other, or more in the complement pathway for the other patients. So a similar insult may have different compartment specific manifestations for different patients. Now, when you look at sepsis, you have patient who's septic with very minimal organ dysfunction. You have another subgroup with sepsis with only AKI. You have sepsis with patients having hepatic dysfunction with DIC. And then you have these patients of subgroup which are septic and they rapidly deteriorated with multi-organ dysfunction, going into failure, refractory shock and death. So all these patients are actually phenotypes. So phenotypes are observable characteristics of individuals due to interaction of genotype, the genes they inherit, and the environment that they presented to. So our main task for using genetics in getting some form of help for septic patient would be to identify the phenotypes, right? Now, among the phenotypes, there are some patients who are behaving in a specific pattern. These are called subphenotypes. Subphenotypes are subgroups with specific multidimensional characteristics within the phenotype. And our target is to identify the phenotypes first, and then to look at the subphenotypes where we can have some useful drug intervening to a positive benefit. A drug which may benefit a subphenotype among a phenotype. That's the whole task of using genetics in septic patients. Now, I'm just going to show you this cartoon. Here, this circle represents what different insults can create SIRS, right? So you can have a patient who has got trauma, somebody who's got post-surgical, somebody who's got infection, or somebody who's got pancreatitis. 4 different ways of insult. But if you can look at the links, the colored rainbows which are connecting each other, they basically indicates whatever is the initial trigger, they may have some common pathways, some common biological pathways with which they are going to create the insult and the SIRS, the sepsis that we so-called call. So we are trying to find what are the similarities among these patients, even though the initial trigger was different. So how do we do that? How do we do this in real time? Okay, so this is a little difficult to understand. I'll try to make it very simple. If you look at the top of the cartoon, you have the same circle with the 4 different insults. The triangles, the grayish blue triangles are indicated of patients presenting with those diseases. So what we do is, for getting the genetic analysis, what we do is we take these patients and we sample their blood, their physiological parameters, all these parameters in a periodic time-based patterns with a certain frequency. For example, let's say we are sampling CRP for these patients. So at a certain group, we're doing 24 hours CRP for all these patients, and we're going to record that. We are going to look at their clinical characteristics, their heart rate, their temperature, their blood pressure, and we're going to record that. We're going to look at their physiological parameters. We're looking at imaging parameters, and then we're looking at the genomic expression in these subgroup of patients. And then we're going to collate all of this together in the middle of the cartoon, the multicolored, the heat wave analysis, and see if we can pick up any pattern that is forming among these patients. Now, after we've done the initial sampling and we have collated the data into the heat wave form, then we use the machine learning, the analysis, the algorithms to see if we can stratify these patients, though they had initial different diseases, into cohorts. And then by defining the cohort, we can then see if we want to target a specific modality, a treatment to that specific cohort. Now, having said that, if you have any drug that you can imagine, IVIG, activated protein C, the cytokine removal system, out of all the patients that you get in intensive unit due to sepsis, trauma, surgery, infections, you have to delineate some way that you can define a cohort of patients that would respond to a specific modality. And this is where all of this gets integrated. The clinical parameters, the genetic parameters, the physiological parameters, the lab parameters, the genomic analysis, the transcriptomic analysis, and the proteomic analysis. All of them get integrated to give you a possible cohort of patients which might benefit from the modality in question. Now, just to make it a little simple, because the previous cartoon was a little complex, what we have been doing till date, what we're practicing is the left of the chart, which is called stratified medicine. We decide the treatment of the patient based on the clinical assessment and scores, the standard cultures, plasma biomarkers, immunophenotyping, and type and site of infections. And this is good to an extent. So we've been able to get patients better. We have had survival, but then we are lacking in certain areas. And we need to move to the right of the chart, which is called precision medicine. You should choose a treatment modality of the patient depending on the genetic makeup of the patient, the transcriptomics, which is the mRNA production, the proteomics, the protein that they produce, metabolomics, metagenomics, and the pharmacogenetics. Of course, we're going to employ the medical history, the patient's clinical data along with these. And for this, then you can define a cohort of the patient where you want to try and first drug, a second drug, and the third drug. And of course, with the drug, similar drug, you can always play with the time interval and the dose. And with this manipulation, you may be able to get a modality of treatment which helps a certain subgroup of patients to improve their mortality and organ dysfunction. How is this done in a real life scenario? So this is a study done from UK, and whatever I'm talking about is the gene expression and the transcriptomics and the proteomics. This study might help you understand better. So what they did in the study was they took almost 262 patients of community-acquired pneumonia with hypoxemic respiratory failure presenting to the intensive care unit for ventilation. Now, these patients are pneumonia, hypoxic respiratory failure, and ventilated. Without knowing what is the clinical outcome, what is the clinical condition of the patient, they just took the blood samples and looked at the plasma leukocyte genomic expressions. How are the genes of the leukocyte expressing? And they plotted this onto this chart. And with this red and blue dots, they were able to see that out of all the 260 patients that were expressing some of the genes, some of the other genes, they were able to pick up patterns. Patterns in the sense that some patients tend to do these genomic expressions. The other patients have these patterns of expressions. And out of when they got to collate the whole data, they found there are two signature patterns. One is the blue one, which is SRS1, and other is the SRS2. Just to recap, these are genetic expressions plotted randomly, and they try to pick up patterns and segregate them into two groups. Here, they have no idea what is the clinical condition or the clinical outcome of the patient. So once we have done, then we have these sepsis signatures defined. What do we do next? There's a big problem. These are total of 3,000 genes expressed. If you ask me that if I have to do a test in ICU which checks 3,000 genetic expressions, it is not feasible. It is not feasible. I cannot do it. Nobody can do it. It is probably financially impossible. So among these 3,000 genetic expressions, they sorted it down to 7 genes in each of the group, which if you do help to segregate patients into SRS1 or SRS2. So rather than 3000 gene testing, you just need to do 7 gene expressions to differentiate your patient between SRS1 and SRS2. What they found in SRS1 and 2 was the SRS1 was the immune suppression signature, where the patient's immunity actually to the sepsis had gone down, and SRS2 was the hyperimmune responding variety of sepsis. Now add the clinical data to this. So let's look at what, if you plot these signatures to the outcomes, what they found was in the left of the chart was the original study, the discovery cohort, that if you chart them together, the SRS1 group of patients, which is roughly half of the patient, and the SRS2, which is again around 56-54% of the patient, you see a stark difference in the mortality. You see that the patient of SRS1, which is the hypoimmune or the immune suppressed variant of sepsis, tends to have a higher mortality, with a hazard ratio of 2.4, right? So after the initial study, what they thought was, is it a fluke? Is it by chance? So now let us look at another 106 patients to see if we can validate these findings. So what they did was, in the right of the chart, they took another 106 patients to validate their findings. Again, they had these genetic expressions segregated, two signatures, SRS1, SRS2. SR1 is immune suppressed, SRS2 is hyperimmune, and they found that the mortality difference again is similar. The immune suppressed variants tend to have a higher chance of dying as compared to the hyperimmune variant, with a hazard ratio even more, 2.8 now, leading to the previous one, but even more. So they were able to validate their data that by analyzing the genetic expressions in a similar phenotype of patients, you can differentiate subphenotypes into SRS1, SRS2, and then see if they have a chances of dying. So for example, after you differentiated somebody who's got immune suppression, so immune stimulating drugs would tend to do better. In the hyperimmune subset, the things which control immunity might end up faring better. So you have differentiated two cohorts of patients, and then you can target your treatment modalities accordingly. Now, after you've done your clinical data, you try to differentiate on the genomic basis. They try to do it in a lot of patients. So this group that we discussed was community-acquired pneumonia. A similar study was done in patients with fecal peritonitis, and the findings were roughly similar. They found two signatures, SRS1, SRS2, SRS1 being immune suppression, SRS2 being hyperimmune, and the mortality difference were likewise. They did in more number of septic patients, in pediatric septic patients. The last study, the bottom of the chart, I would like to draw your attention, was the largest database that they have done. Though it a retrospective analysis of septic patients from almost 14 trials, they were able to gather 700 patients. Here they were able to differentiate them into three subphenotypes. The inflammopathic, which is basically pro-inflammatory complement pathway activation; adaptive, where the adaptive immunity and the interference signal was there; and coagulopathic patient, where there was platelet dysfunctions. So rather than two, they had three subgroup phenotypes to be identified, and with identification of major disaggregated pathways or types, they can direct selective treatment. So there's a lot of data that's been available. A lot of the data is retrospective, some of them is prospective, but the findings are roughly similar, that among the same disease like pneumonia, peritonitis, maybe UTI, you will be able to differentiate patients based on the genomic expressions and then choose your targeted therapies. Now, how do you target your therapies? After you've done the differentiation of genomic analysis, how do you target the therapy? Now, this is beautifully done in the Sigma study. Now, the Sigma study, as we all understand, IVIG doesn't have a strong recommendation for use in septic patients as per the Sepsis Guideline 2021. But recently, we have an IgM-enriched IVIG called trimodulin, which is supposedly better for septic patients for immunomodulation. Now, this particular study tried to look at this particular IVIG, the IgM-rich trimodulin IVIG, and it affects on the community-acquired pneumonia patients admitted to intensive care unit with hypoxic respiratory failure. The primary endpoint of the study was ventilator-free days, and the secondary endpoint was 28 days mortality. Now, unfortunately, when they looked at the patient's N block without doing any subgroup genomic analysis, this was a negative trial. When you do IVIG for all patients, irrespective of the caste, creed, and color, you do not get any benefit by giving IVIG. So, trimodulin did not have any difference between the two groups based on the ventilator-free days or the duration of mechanical ventilation or the mortality, time to discharge, stay in ventilation, vasopressor weight is none. But then what they did was they tried to do a subgroup analysis based on biomarkers. So this is the negative study. When they tried to look at the biomarkers, they said, let's look at the subgroup of patients which have high CRP, CRP more than 70. Let's look at a subgroup of patients who are IgM deficient as a response to sepsis. Let's combine these two. Let's combine patients who have a high CRP and a low IgM. And then let's look at patients who have high procalcitonin. And then see if these subgroup of patients fared any better to IVIG as compared to the whole cohort, right? And we got surprising results. When you do a subgroup analysis and you see if you're able to choose the patients on the basis of the CRP or the IgM levels, a CRP more than 70 and a low IgM levels, you got an absolute reduction of mortality of the tune of 25%, which is huge. Where you had a negative study, no improvement. In a subgroup of patients, if they were chosen more carefully based on the CRP and IgM levels, you would have drawn a benefit of nearly 25% in your 28 days mortality. And that's where our subgroup analysis tells us that the phenotypes have to be picked up, subphenotypes have to be defined, and the treatments have to be accordingly targeted. In this particular patient, the phenotype is basically pneumonia patients with hypoxic respiratory failure. The subphenotype is patients who have got pneumonia and hypoxia with high CRP and a low IgM values. Another very interesting study, which was done a few years back by Shakuri, what they did was, the bottom of the chart is, what they did was, they picked up a study done 20 years back and they reanalyzed the data. The initial study had looked at the IL-1 receptor antagonist and Kinera to see if that has any improvement or mortality benefit, any kind of benefit to septic patients. It was a negative trial 20 years back. When they reanalyzed and they tried to pick up patients who have hepatic dysfunction, hepatobiliary dysfunction, and DIC, which fit into the criteria of macrophage activating system, and roughly 6% of the patient of the previous trial had features of macrophage activating syndrome. They found that in this subgroup of patients, when this drug was employed, they got a 30% improvement in mortality, which is huge, So what people are trying to do is, in different trials, and there are a lot of trials, I cannot put them all in my slide, is that there are a lot of prospective data and there's a large retrospective data as well, where people are trying to look at the previous negative trials and see if any subgroup was there which actually drew benefit from that particular intervention which was planned. Likewise, there were trials that showed there was benefit in subgroup of patients who had a monocyte HLA-DR less than 8,000 antibodies per cells for GM-CSF, and so on and so forth. So there are a lot of drugs which are coming up which could have benefited in the trials if they had chosen the right subgroup of patients. And that is where I'd like to end my presentation. Thank you very much.
Thank you, Dr. Himanshu. It was an eye-opener for all of us as to understand the genetics of sepsis. And I was of the opinion till now that hyperimmune response is more dreadful compared to the hypoimmune response. And I also used to personally feel like hyperimmune response is more contributor pertaining to the inflammatory response which is associated with organ dysfunction and organ failure. But these studies are like an eye opener for all of us. But we'll
See,
have questions later on. I'm waiting for Professor Bingold. Please stay with us. I would like to invite Professor Bingold. He's from Germany, and he would like to highlight the key points about organ support. Uh, we have been very thoughtful about the organ dysfunctions like liver dysfunction, kidney dysfunction, and all that. But we never look at the metabolic derangements. Okay, and metabolic derangements are never considered as kind of a failure of any organ system. But how do we control the metabolic problems? And then there are devices also which are available. So, Sir Dr. Tobias Bingold, can I invite you to share your screen and continue the session? And after that, we will have
Yes,
question
of
and answer. Yeah.
yes, of course.
Good
Thank
evening.
you.
Good
First
evening.
of all, thank you
Very,
very
very
much. You can
yeah.
understand me? Yeah, okay.
Yes, yes.
First of all, thank you for the invitation. I try to share my screen. Mm. So,
Yeah, the
yeah,
screen is visible now. Nicely.
very good. Yeah, I'm medical director from the AVITOS company based in Munich, and it's yeah, I'm appreciated to have the chance to um, talk about our device for the next minutes. Um, what I would like to present today is first a short view on the company, who we are, then what the system is about, and what is different to the systems on the market, and what is insights in pathophysiology behind that, and first clinical data and perspective indications for the system. So the company is just small. We're now in 23 ICUs in Germany and in Austria. We've done since the invention of the uh, company about 10,000 treatments now in patients since 2013, and about 1,400 therapies per year. The founder was Professor Bernhard Kreimann. He was a nephrologist, and he had the problems about in the late 90s, beginning of 20s, that there was no possibility to remove protein-bound toxins from patients. Mainly, one of the key patients why he tried to go further with a patient with copper intoxication with a morbus Wilson. And so he was one of the first who tried to make single pass albumin dialysis to remove this toxins, and it works. And so he was further going on and was looking at, okay, single pass albumin dialysis is not that effective, and it's very cost intensive. So he was trying to focus how we can get to a machine which is doing this albumin dialysis more efficiently. And so in the first phase, sorry, in the first phase in 2005, the company was invented, and the first the laboratory setup was done, and the prototype for animal studies was done, and it took until 2014 until we get the CE market sign and could start really in patients, treating in patients. And further development was done mainly in 2018, 2019, where the concentrates and the working of the machine and from technical side was changed, and the rebranding to the company AVITOS was done. So from the history, it came from liver support, and it's now one of the devices where you really could treat patient individualized and active acid-base balancing and doing multi-organ support. What's it about? If you look, it is a classical dialysis machine, as it was invented by a nephrologist, and it works with the extracorporeal circuit here on the left side, and the blood is running through the dialyzers, and you see we have two dialyzers as we need it for the contact time for biochemical reactions, and therefore we are, in difference to some other systems, are working with more or less low blood flows with 100 to 300 ml per minute. The second circuit is a dialysate albumin circuit. It's containing 2% albumin, which is reconstituted in the third circle. And so we have here in the blood circle dialysation, and we have on the reconstitution circle a filtration. So it's a hemodiafiltration system. And there are two special things. One is the way the reconstitution of albumin is done. It's done by adding acid and base. And the second is, and the second point is it's a recirculation system. So if the dialysate flow, it not all is going to a reconstitution, but there's a certain amount going in a direct recirculation. And that means, in difference to single pass systems and to absorption systems, that if you have small concentrations of a substance in the blood, you can't not really remove it. It's on the one side, if you want to remove it, it's not good. But on the other side, you have in classical dialysis mainly the problem that you also remove substances in small doses, which you don't really want to remove. How does it work with the acid base? We're adding on the one filter sodium hydroxide with 42 degrees. And by that, the albumin constitution will change. As it's a protein, it's pH dependent from its three-dimensional structure. And by changing the three-dimensional structure, toxins will be removed from the albumin. And on the one side, in the base side, and on the other side, in the acid side. But further, you can change the pH in the system by changing the ratio between base and acid. And therefore, you can set the pH of the system, and therefore you can do an active acid-base treatment. And how does it work? It works primarily in the Henderson-Hasselbalch equation. It's CO2 plus water is getting H plus bicarbonate. And if you put up the dialysate pH on this side here, it's a dialysate side, and this is a blood side. And you have a pH of 9.0. And on the blood side, there are acidosis below 735. You have a strong diffusion gradient between the blood side and the dialysate side. So you can dialysate like sodium, like creatinine, H plus to the dialysate. On the second point, you have albumin, and albumin is an ampholyte, so it can carry positive and negative substances and is a strong H plus carrier in the blood. And therefore, if it's reconstituted in the dialysate, it can remove up to 20% of the removal of H plus we're doing with the machine is done by albumin. And the third point is you have HPO4 in the concentrates, and therefore you can have a binding of H plus, so you have phosphoric acid. And on the other side, you have bicarbonate. And if you look on the equation, CO2 plus water getting H plus HCO3, when you remove H plus from the blood side to the dialysate, the equation will have increasing concentration of HCO3. So if you treat these patients for 1 to 2 hours, bicarbonate will rise. And so you will stop regulating the pH. Otherwise, you have to change the bicarbonate concentration in the dialysate system. And so we have 3 different concentrates with 20 millimoles, 10 millimoles, and 0 millimoles bicarbonate. So we additionally could adjust the diffusion gradient between blood and dialysate depending on HCO3. So we have 2 different ways to remove acid. And to have a view or an imagination how high this diffusion gradient is, if you look in a solution with a pH of 9, you have a concentration of 1000 H plus per nanomole per liter in the solution. And if you look on a pH of 7.2, 7.3, you have nearly about 100,000 nanomoles. So it's a constant diffusion gradient between 1,000 and 100,000. It's a very strong diffusion gradient. So it works very good to remove H plus from the blood side to the dialysate. But it's only one half of the truth. The other one, if you look further on at the base balancing, you have to look on the Stewart model. And then the Stewart model mainly add to the bicarbonate and CO2H plus. The sodium and chloride. So you have sodium is the blue column and green is the chloride column. And if you see in consumption, acid-base balancing, there are very strong indicators or changing factors for acid and base. So we know we can change the bicarbonate and we can increase the sodium and we can decrease the chloride. So by decreasing chloride and increasing sodium, we will have an increase in pH by increasing the SID. So that's an additional effect. And so if we change the dialysate pH in the machine up to 9 here, for example, the concentrate acid base ratio will be changing because you're increasing the base ratio, the base concentration, the ratio will fall, and therefore the pH will rise. And in the concentrates, parallelly, when you in the concentration with reduced bicarbonate, the sodium concentration is higher and the chloride concentration is lower. So we have additional effect in this way. Why it's so powerful to make acidosis treatment with dialysis. If you look, what is the blood content of acid and how is it is the distribution? You can see here it's a concentration of 0 PCO2 to 80 PCO2. And you can see, okay, the load of acid in the blood will increase. But if you look, we are normally, when we're working, for example, for CO2 removal, extracorporreal CO2 removal, you have only this small part of CO2 we can work with because the most amount of acid is based in the bicarbonate field in plasma and erythrocyte. So by working with a dialysis system, you can work with this huge amount of bicarbonate, and therefore you can also remove acid from the slower compartments. As you see, if you add acid, it's mainly CO2 from the supply tank to the patient, or is produced by the patient. You have the rapid compartment, and that's mainly the blood. And then you have your interstitium with medium compartment and the slow compartment in the cells. And therefore, you need more time to mainly change these settings in the medium and slow compartment. Therefore, you need normally up to 2 to 3 days really to change these low compartments from acidosis. Why do we use 2 dialyzers? This image shows very properly if you have a concentration of 30 milligram per deciliter bilirubin in the blood and you use one dialyzer, you can see, okay, you have a removal or to the half to 15 milligram per deciliter. But if you're working in the system with 2 dialyzers, it's an orange line, you can see you can even remove up to 8 milligram per deciliter. So it's much more effective to work with these 2 dialyzers in detoxification, but we have the same data for the acidosis treatment, you can receive much more H+ in this time. So the AVITOS circuit has three mainly functions. It's renal acid-base compensation, and we have a renal acid-base compensation because it works like the kidney is balancing acid base in the human body. And we have a renal hepatic detoxification, removing water and protein-bound substances, and we have a regulation of fluid of the fluid balance by removing water as needed. So what is the difference? It's no absorption system. It's no single pass system as we know it in a classical CVVHD or in absorbing systems with absorbers we add to the circuit. But it's a recirculation system. It's from my point of view quite big change in extracorporeal renal and multi-organ replacement therapy. Looking on substances, we remove additionally when we look on protein-bound toxins we can remove. So it's protein-bound uremic toxins, and it's a substance which in the last former years now, there are much more investigation about it and about the effect. And one main effect of it is done in that was looked for in this trial. There were patients with acute kidney injury, with new acute kidney injury for patients admitted to the hospital. And we know in inter-organ crosstalk, mainly very much about the interactions of different cytokines, chemokines, which play a major role in that. But we have additionally substances like indoxyl sulfate. It's from the tyrosine, a product of tyrosine, and it's the problem is it's a protein-bound substance which is normally removed from the blood by secretion from the kidneys. And if you have a kidney injury, these substances will increase in the blood. The second organ which can remove it is the liver. But if you then have additionally liver dysfunctions, you have a severe problem, because what we know about indoxyl sulfate is that it's one of the substances who removes the tightening of the cell contacts. And there was this one substances which is mainly connected to pulmonary edema, reduction of the cardiac function, and mainly also in the intestinal system for intestinal edema. And we know from studies from uremic toxins that indoxyl sulfate is one of the substances who is in charge for cerebral edema. So it's quite interesting to look at it, whether we can remove it or not. And yes, we know that it's connected to mortality. If you look, it's a prospective cohort trial from China who looked on acute new acquired kidney injury also in hospital in 262 patients. And you can see if it's below 7.4, you have a much higher surviving rate than in the group with values above 7.4. The problem is, yes, we have actually data that it's one factor associated with higher mortality rates. We have no really data up to now what is the change or the influence if we treat this. We will do that now in prospective trials starting in the beginning of the next year. What we know already is from chronic kidney disease patients that if you treat with the AVITOS multi-system in comparison to classical hemodialysis, it's picked up here. This one is 6 treatments with the classical hemodialysis day over day. And then it was changed to the AVITOS system, and you can see that yes, classical hemodialysis is removing in a certain amount indoxyl sulfate. And what we can see if we do it with the AVITOS system, it's even more. And if you see, it's also quite another interesting fact. If you do intermittent hemodialysis with different anticoagulation systems, the potential for removal of protein-bound toxins will get less, while it is with heparin and with citrate in the AVITOS system the same. So quite interesting data, and we're looking forward to get here the clinical data, what will be the effect on patients if we remove it in septic conditions. The other substance is albumin in the system where we're working with. So it's a three-dimensional huge protein. As I told before, it's an ampholyte, so it can bind anions and cations. And you see it's a huge list of substances connected to this protein. So if you're doing an albumin dialysis, you always have to think about, yes, you want to remove toxins and substances you want to eliminate. But on the other side, you have also substances you don't want really to remove, or you have mainly also antibiotics bind to albumin, which you have to look at how you will do the dosing for that. And even more, you have to be very careful, mainly in critical ill patients, by treating these patients, example, if with sulfonamides as furosemide or different antibiotics, you will reduce the binding capacity for bilirubin to albumin. And therefore, if you do that, the removal of bilirubin will be less, because if you will remove bilirubin from the blood to the liver, you need albumin as a transporter, otherwise it doesn't work. So in critical ill patients, we reduce the possibility for the liver for the detoxification due to our medication. And therefore it is to be discussed that it is one of the reasons for progressing multi-organ failure in these severe ill patients. Therefore, we were looking in vitro data this year, what is done with medications we give. And this is, for example, you have to first look for the protein binding, and we tested that the protein binding is by adding albumin to swine blood is the same as it's written in the literature for the human blood. And then you have to look, okay, how high is the clearance rate normally in the blood for a different substance? Because if you're looking here for valproic acid, example, it's about 1 liter per hour. In comparison to that for pyrmeryprim, it's about 13 liter per hour. So it's quite different from, and that's what we see in the half-time of the substance. But you have to look at that if you're doing a dialysis. And therefore, we compared a classical CVVH D system with the AVITOS therapy, and looked how is normal renal clearance in blue and extrarenal clearance in yellow. And so what you can see here, for example, for ceftriaxone, the normal clearance rate is about 1 liter. So we have to reduce the substance in patients with acute kidney injury and renal replacement therapy, because the clearance is only 0.2 liters per minute per hour. And if you treat these patients with a AVITOS system, you have to be careful, because and then you have a higher clearance rate than the normal rate. So it's 1.1 normally, and it's about 1.3 liters per hour with the albumin dialyzing system we use. And if the liver still works, and because you're doing primary acidosis treatment and kidney treatment, you have the additional effect from the normal removal by the liver. And it's different between the substances. It's ceftriaxone, cefotaxime, for example, and you can see here in this trial further that if you increase from a normal concentrate flow to a higher concentrate flow, that you will increase the removal of the substance. That we done for other substances again, and also here for a very important substance. If you think about endocarditis, for example, for daptomycin, it's about 0.6. You have to reduce the dosage if you're doing a normal CVHD, and you have to significantly increase the doses if you're using an albumin dialysis system or as we make the data for our system now. It's only on a major impact for oral anticoagulation substances like apixaban, dabigatran, or like fenprocomone. Here it's a very also significant difference in normal half-life time is about 8 days, and if you're treating with the ATRA system, it's about 8 hours. So you have to really look when you treat patients with the system, what you're doing with your normal medication. What we can see is that there's a quite good removal for lactate on the one side. So lactate is here in the blue-green line, and you can see a adequate fall in the line and therefore adequate removal of the substance. And we also tested the IL-6 concentrations here from 500 picogram per milliliter, the removal in the first 4 hours. And we did it in different concentrations, and we can see that in 500, 2000, 10,000 picogram per milliliter, we have a removal of 60 to 70% in between 12 hours of the substance in an in vitro model. So what is it be adjusted by the machine? You have 5 wheels to adjust. It's first the blood flow. And as I said before, it's normally about 100 milliliter per minute. You can put it up to 500 ml per minute. That depends if you want to remove small substances like H-blood or you have a very high bun, what you want to remove. That's why you increase the blood flow rate. The pH setting is dependent on the pH of the blood. Same as the bicarbonate, you can set between 20 and 0. And the concentrate flow is the removal or the rate of reconstitution of the albumin circuit. And that's also the same. You normally do it with 160 ml, and you can increase it for small substance removal to 320 ml. And the fluid removal is about ultrafiltration between 0 and 500 ml. You have regulatory control parameters because you adjust also magnesium, calcium, potassium from the blood, and you have to look that you be in the range. So what is the intended purpose of the machine? The intended purpose is, as I told you before, to remove water-soluble and protein-bound toxins, to normalize or improve the composition of the blood, mainly in electrolyte or acid-based disturbances, and classical for dialysis system, the removal of fluids. And the patient's group defined is patients with renal failure and or acidosis and or acute or chronic or acute on chronic liver failure. It's not intended for the use for children. It's due to the fact that the extracorporeal system will have amount of 430 ml of blood. So if the blood volume is too low and you have severe problems with hypertension and things like that. For pregnant women, we don't have enough data and prior diseases excluded. You can make it, but then the machine after that can only use for patients with prior diseases because there's no disinfection protocol at the moment, which is validated that the machine is really free of prions after that. Have a look, just a short look of base balance. Why is it useful to look at it? As like we know in intensive care medicine from blood glucose control and other things, we have mainly in the most cases a U form from the values. We have a certain area where the mortality rate is the lowest, and if the value is too low, we have a problem, and the value is too high, we have a problem. We see the same for bicarbonate, we see the same for the arterial pH, and therefore it's useful to think about to treat these patients. Nevertheless, and to date, we have no really opportunity that we can, with extracorporeal systems, treat acidosis in these patients in a timely manner in a patient individualist form. So therefore, data for comparison are still missing, and so that's why we are starting the first multi-center trial in the next year to look at this further, because only in severe respiratory acidosis with the ECMO system, it was really possible to make an acid-base balancing. That the acid-base balance is playing a major role. You can see on this graph here, there's a two group of patients with the same acidosis in the beginning of on day 0. And what you can see, the patients surviving, yes, have on the first day a normalized pH, while patients with a continuous in acidosis have a group of patients who not survived this. And it was also in a multivariate analysis parameter was significantly adjusted to mortality. So we have to look on this problem. We have no really good data, but we further see that in multi-organ dysfunction, mainly when the liver is associated, and mainly in patients who not primarily have a liver disease, have a major impact on mortality. And so if you look here on endocarditis patients have a serious problem, the normal mortality without with normal hepatic function is about 60%. If you have a septic hepatic failure, it's about 40%. And if you have patients with acute and chronic liver disease, you have only a survival rate of below 25%. So it has a major impact in the standard care of intensive care medicine. For these critical ill patients, we are not suffering for that, and we are doing normally no liver dialysis or have not very good data for that, whether we can improve these. This is the same for patients in RDS. I don't want to go further on that, but I would show in the next few minutes the clinical data we have. On the pyramid of evidence, we are on the lower side, not on the top. We have no systemic reviews, the meta-analysis, randomized control trials, but we have some cohort studies and case control studies. And what we can see, and what I summarized here, is that we have a dose-dependent reduction of protein-bound toxins, here measured by bilirubin in different cohorts. We have measured in a registry included, and what you can see is this is here's depicted the values of the bilirubin before the adverse treatment. And depending on the cohort, you see a certain amount of bilirubin reduction here depicted in percent, which is depending on the rate of bilirubin in the blood. And as I told you before, it's a recirculation system. So you have to look that if you have lower concentrations of a substance, the removal which will be lower than if you have a higher concentration of the substance. It has a good performance in removal of water-bound, water-soluble toxins. And here's one quite interesting cohort, because acid-based treatment, meaning also in respiratory acidosis, fluid-based CO2 removal. And it was a case here done in the COVID pandemic last year. That was 9 patients in the University of Munich, which had contraindications for ECMO therapy, while having mainly the indication that ECMO therapy would be needed. And so very severe ill patients with a standard therapy of these patients. And they were treated with 300 ml blood flow for a quick resolution, and with a pH of 8.8 and a concentrate flow of 320 ml per minute. And what you can see on the data, only in a short view, yes, we can remove CO2 from 66.2 to 52.2, in the end of the therapy to 47.8. This means in the mean CO2 removal of 49.2 ml. So of course, and that's not the indication, it's no ECMO system with an ECHO 2Rs removal of CO2, but it's about 30 to 40% of VCO2 production could be removed by the system. So in patients with a multi-organ syndrome, this could be additional effect to stabilize the ventilation of the therapy. if the CO2 values had been very high in the beginning, it's a maximum removal of 160 ml per minute to be measured. And on this slide, you can see a 2-year interims analysis of data which had been collected between 2017 2019, 118 patients. What I would like to show in this picture mainly if you look on device-related complications, it's a quite stable system. Yes, of course, you have clotting. These patients were still treated only with heparin and without citrate, though these rates are still decreasing further. But the treating physicians not documented any adverse event, mainly in connection to the adverse system. And in looking on these data further, we did a the group did a standardized mortality ratio of these patients. If you look from the conditions, it's about 58 years old, so 63% of males, and means SOFA score of 15, so quite ill patients, mainly with liver disease in the primary indication for the treatment. And what we can see is overall, looking on the group, we have a SMR of 0.7, which is significantly better than the observed mortality, is significantly better than the expected mortality in patients. And that's why we were looking further on acidosis. We could see also a trend to a better survival rate, but these patients were treated with no change in the pH and no change in the concentrates. So it was just in the beginning where it was not adjustable like it is now. That's why we are running now, or will start to run now, new registry and additionally multi-center trials to look at that further. As recirculation system, you can see what I showed you before. If you look on the bilirubin, if you have high concentrations, you have a relative reduction in the mean of 23% in 97% of the treatments. If you look on 6 to 12 milligram per deciliter, yes, you have a reduction of 10% in 86% of the patients. And if it's below, yes, you see more or less in the statistically no difference, and you see a reduction in 38% of the patients. So the lower the concentration, so the less the working of the system. But what you can see further, that we have a good reduction in norepinephrine in very high concentrations, and also in low concentrations there could be this improvement for the patient. And that's, you can also see if you look on the delta P for the invasiveness of the ventilation, mainly in patients with driving pressure before treatment of above 20, there's a reduction of 17% in 75% of the patients. So it was not just a cohort really looking on RDS patients, but it was a cohort with multi-organ failure patients. We've looked also, or we're looking at the moment, and one clinic is looking there comparison from plasma exchange with adverse therapy in ACLF patients. And they have a cohort of 71 patients, and in the cohort one with ACLF3, grade 3, 47 patients. And what you can see in the overall cohort, and that's why we were looking, although the group is looking only for ACLF3, is that in the plasma exchange group, the CLIF ACLF score had been significantly lower than in the adverse treatment group. And that's why we are looking only further in the data for the ACLF3 patients, because they were comparably from the number of patients treated and from the CLIF ACLF score. And if you look on that, it's depicted here. For the 14-day survival, we have a significantly, yes, it's too low patients, but we have no inferiority for the patients with adverse treatment, because if you look at 36.4% survival patients against 20% for the gold standard with plasma exchange. So quite interesting data. And what we looked further for that, there was no change in the data for the CLIF CF score in the first 7 days. but what we can see is the SEPS2 was significantly lower after 1 week of treatment for these patients. And if looking on the SOFA scores by organ, we can see that there was a significantly lower SOFA score for the lung after 1 week. So SOFA score 2 for the plasma exchange group and SOFA score 1 for the adverse group. And there were less patients on ventilator on that time. The hepatic encephalopathy in both group improved and were significantly lower after 1 week. And the last data I want to show you there is no influence to low levels of cytokines. That's a group in Mainz in patients with post-ACLF, which had been treated by that, and the inflammation levels had been very low. So it's look under the IL-6 columns. It's about 100 picogram per milliliter, and there was no change before and after the treatment. That means if you treating patients with extracorporeal system, it's known that you have normally a small increase in inflammation, so we don't see that. And for me, the more important data is that you have no change in the anti-inflammatory side and in the inflammatory side. So because the main goal of blood purification therapy is to get a steady state and a new homeostasis for these patients. And you have the problem if you're using an absorption system or single pass system that you will remove all the counterpart like IL-10 also in low doses, and you will reduce that. So it's quite difficult for the patients to get into a homeostasis. That's one point we will look on one of the next trials also. So the perspective, what are we for? It's mainly for critical patients, meaning patients with acute kidney injury plus a shock syndrome, plus minus a respiratory or metabolic acidosis. And the underlying disease can be one of the liver side, of the cardiogenic side, or of primary bioinfection side. So we have different patients groups, which will be potentially suffering or have an increase in survival rates by the treatment. We are looking now in patients with ACLF. In further trials, we're looking in posterior cardiac surgery, mainly in new trials, and we are looking in patients with sepsis in prospective trials to look for the detailed effect of the system. Very good is we can use citrate anticoagulation for the system. We can treat further patients with mainly intoxications with protein-bound substances. So thank you for your attention.
Thank you very much, sir. It was a nice session to cover with this machine. That's very much elaborative for this exam going students. There's one question in chat box which was asked by one exam going student. It was related to steroid. It was I request Dr. Jui to answer that question. That whether we can we give that steroid from bolus dosage or in continuous infusion.
Yeah, so basically, it's according to the surviving sepsis guidelines, they recommend giving steroids up to 200 milligram of hydrocortisone per day. It's recommended to give in an infusion form. However, if you give as 50 milligram QID also, it's not, it doesn't make any difference. So if you have limited access ports, like, in your central line, and you can't use a port to give your continuous infusion, then you can safely give 50 milligram QID. Yeah. So hydrocortisone is the recommended agent when you're giving for septic shock, but the timing is very important. You give it when you start your second inotrope or you have already going up on your noradrenaline infusion. And you can't meet your target of 65 millimeter of mercury BP at least. And you ensure that your patient is adequately filled, of course. Yeah. And only in sepsis, like not for sepsis.
The advantage is there is no glucose fluctuation actually if you give it in a continuous infusion, and the fluctuation in the sugar level is more detrimental. So that's why the continuous infusion was advocated. But recent guidelines 2021 has not given much emphasis on continuous infusion versus intermittent.
Bolus.
It depends upon the clinician's discretion and resources that we have available. And I think both are equally efficacious. Even intermittent would be more equally efficacious if it is not causing much fluctuation in the sugar levels. This is a feel so.
And you're using IV
Dr. Divya,
insulin to maintain your sugar anyway.
yeah, then you will have to continue with another infusion of insulin.
Yeah, yeah, yeah,
Yeah.
absolutely.
Yes,
That
we
is the
have Dr.
problem always.
Divya. Yeah, Dr. Divya, I mean, what do you think about the organ support as far as pH control is concerned? Professor Bingold has been quite instrumental in advocating control of pH and metabolic parameters. So, can we similarly control the metabolic parameters with the CRRT? And your suggestions on that, Dr. Divya, if you're there, would you like to take the question? Dr. Swapnil?
So, uh,
Divya ma'am is not there, sir. Divya
Yeah,
ma'am is left, I think.
yeah. So, what do you think? I mean, CRRT, would it be equally efficacious compared to the new device that is, advanced? What do you think about it?
Sir, basically, when we are using CRRT, we just have to control the hemodynamic. That was the better indication to use CRRT other than SLADE. Anyways, if we are considering the mortality benefit, there is no much difference in SLADE or CRRT. But yeah, with the help of CRRT, they are saying we can use multiple types of filters, like cytosol or those cytosol or that auxiliaries. But again, there is no much proven mortality benefit with it, and few of SLADE machines are equally equipped where we can use those filters. So, sir, it just probably in our setup, we usually go ahead with the hemodynamic instability where CRRT can be beneficial. That is
But the
the only thing
CRRT
we are.
may not be efficacious enough. Yeah, the CRRT may not be efficacious enough in acute conditions, especially in patients with a post-arrest situation where you will find the pH going below 7, 6.7, 6.9 or something like that,
Definitely,
which
sir.
is associated with
Definitely.
a high mortality. CRRT will not be able to control that acidosis. And on top of that, if there is acidosis, the vasopressor requirement also goes high. So my question to Professor Bingold is like, how efficacious would it be, like continuing with the AVITOS compared to CRRT? As far as the control of pH and bicarb and electrolyte is concerned. Because in post-arrest situation, no matter whatever you do, whatever intervention you do, the pH doesn't get controlled. So how efficacious and
yeah.
how much time duration will it take to control the pH and the electrolyte disturbance?
Okay. I think first of all, it's really the system is not in competition to a classical CRRT system. Because it's really only for a severe multi-organ dysfunction situation, and it's not a standard CRT. And because if you look, the change of pH in the system is normally working into 1 to 2 hours. As you can get a patient from a pH of 6.9, 7.0 to 7.3, 7.4 in between 1 to 2 hours. So it's a very quick change. And patients we see the most improvement is who have, through the shock syndrome, also lowering in cardiac output. Because by normalizing the pH, the cardiac function is improving very much. And so you can see that the cardiac output significantly increases, and the microperfusion of the fingers and things like that are getting very much in a very short time much better, because you can reduce norepinephrine and things like that very quickly. But if they have the most important thing is that the patient has an indication for a treatment, because if the patient is already dying and there will be no change, the machine will make no change. So the underlying disease must be in a condition where we say, okay, there's really an indication and a hope that it will get to stabilization and a condition where the patient can get home again.
Thank you very much, sir, for that input. I think there's no more questions in. Let me just check once. No, ma'am, there's no more question. One more controversial thing, they are saying that fludrocortisone can be added with the hydrocortisone. So, ma'am, is there any recent development in it?
Fludrocortisone was considered to be added as a sort of like as an aldosterone replacement, because hydrocortisone is more like an anti-inflammatory and it's more of glucocorticoid effect. So as a mineralocorticoid, they considered adding fludrocortisone, but as such, it has not shown any mortality benefit. But if you have hyponatremia along with that, so maybe fludrocortisone addition may help you if it is not able to correct with hydrocortisone alone. But as such, just for hemodynamics, I don't think it is, evidence has not shown to be in favor of that.
Definitely. Ma'am and sir, there's no more question in.
You are muted, Swapnil.
Hello, yes, ma'am.
Now we can hear you. We could not hear you before. Yeah.
Oh, yeah. I was getting call. I just put it on hold. So, okay, ma'am and sir, basically, it was. Sorry for the time. It was very much pleasurable to have such informative sessions in combination of the with this all three topics. So specifically, I'm speaking about on behalf of these exam going students. So I'll really thankful to you, and I think we look forward to continue all those sessions again and again.
Sure. Thank you. Thank you. It was our pleasure too. Thank you.
Thanks, ma'am.
Thank you.
Thank you.
Thanks, sir. Thanks, sir. I think we will conclude it over, sir.
Thank you.
Thanks, ma'am. Thanks. Bye. Take care.
Thank you, everyone. Thank you.
Thank you.
Take care, sir. Thank you very much, sir. Thanks. Bye. Take care.
Bye-bye.
Bye.